So again, welcome to everyone who are joining us this afternoon. We would like to acknowledge the traditional owners of the land and acknowledge that for Aboriginal people, it is an interconnected set of ancient and sophisticated relationships. University of Wollongong spreads across many interrelated Aboriginal countries that are bound by this sacred landscape and intimate relationship that those people have from Sydney to the Southern Highlands to the South Coast, from freshwater to bitter water to salt, from city to urban and rural. I myself am coming to you today from the land of the Gidabal people in the Southern Downs in Queensland, and the university again acknowledges the devastating impacts of colonisation on our campuses and footprint, and commit ourselves to truth-telling, healing and education. So I would just like to pay our respects to elders past, present, emerging and future. Now, we will take a quick moment for everyone to sign in. If you cannot sign in, that's okay. We can sort that out later. But if you have a device handy that you can sign in using that QR code, this piece of education and learning today, we can send you out an attendance certificate for this. So I'll leave that code up online on the screen there for a few seconds, just so everyone can capture that. And if we need to put that up again towards the end of the session, once we're finished, we can do that as well. So today's webinar, we are going to be talking about the deteriorating resident who falls. Basically how to assess them and what tools and ways within the PACOP framework we can use to do that. So we're going to go look at the key assessment tools in PACOP profile, when to use our deteriorating resident tool, and talk about should our frequent fallers actually be in the outcomes collection. Now, part of that conversation also delves into quality indicators and PACOP and making sense of what we already know, what we already count and record as part of our everyday practice in a residential aged care setting. So just a bit of a reminder, some people in this webinar session today might be brand new to PACOP. Some of you attending today may be aged care homes who are already using the PACOP framework. So the framework itself is made up of two parts. We have the profile and the outcomes. The core activity of profiling, which is the first part of the program, is our routine monitoring, assessing and screening of residents to understand their needs and determine whether those residents in fact have got palliative care needs or not. We talk about embedding new clinical language in that part of the program and facilitating early identification. Now, after the profile component of the framework, we go into the outcomes component of the framework. So our outcomes part is where residents have already been profiled or screened using the deteriorating resident tool and have entered into the outcomes collection. The residents or people in the outcomes collection, we know definitely have identified palliative care needs. And that's when our episode of palliative care effectively starts, when someone enters the outcomes collection. It's a point of care assessment for the palliative care needs. We're looking at symptoms, distress, problems of the resident, their families. We have our evidence-based clinical response protocol that guides timely responses, because the frequency that we see to people in the outcomes collection is going to be more frequent and higher than someone that is alone just in the profile collection. The process, some of you, again, this may be a familiar slide. We're looking at profiling, the three-part clinical assessment tool, parts A, B and C. We're looking at on admission to your aged care home and in a minimum of every 3 months in line with your routine, regular, comprehensive assessment, and also on return from hospital, because we know people that come back from hospital are quite often not the same version of the person that left. So we need to, again, do that palliative specific assessment to get an understanding of what we're dealing with, what that person's needs are when they get back from hospital. Within our profile collection, you'll also see that our deteriorating resident tool. So that is our grab and go tool to use in between our routine 3 monthly assessments when there is any concern in between that 3 monthly period. And by doing each of those parts of the profile, we can then have the information to tell us whether that person in fact needs to be in the outcomes collection or have an episode of palliative care. So you can see there as well, a lot of you will be familiar with the daily SAS. So the residents that are in the outcomes collection, we are looking at them with palliative care eyes via the daily SAS every single day to work out what palliative care phase they are in, what's going on for them, does something need to be changed, are their needs being met, is everything working for them? And we also have a resident snapshot there as well. So we may have residents that sit in the outcomes collection for 3 months or beyond 3 months. And when it gets to that point, we fill in the gaps of what was missed or to supplement what would have been completed if that person was in the profile alone. Again, this slide may be familiar for some of you, but for those of you that interpret flowcharts a little bit better, this is what the PACOP framework looks like in a flowchart. So on the left there, you can see our 3-part clinical assessment in profile for our new and existing residents. During that process, we will find that a resident may or may not meet the criteria. You can see there, yes to 2 or more of the assessment criteria. If we are finding yes to 2 or more of those assessment criteria in Part C, we will say that yes, that resident would benefit from palliative care. Alternatively, that resident may not actually have any indicators that those criteria are being met. And we may say, no palliative care criteria met at this stage. We can keep that person on a 3 monthly cycle, knowing that if there's deterioration in between that 3 monthly period, we can use that deteriorating resident tool to identify whether at this point in time that person has got sort of palliative care needs or meets the criteria for palliative care, in which we will enter the outcomes collection. So today we're going to go through a case study that will apply those and talk about, who we're calling ESME today, people who might be quite frail, who might fall frequently, and how we can apply the PACOP framework and the tools to a resident that may look like ESME. So let's talk about ESME and introduce her. She's 89. She has lived in an aged care home for 18 months. Her diagnoses include advanced frailty, osteoarthritis in her hips and knees, vascular dementia, mild to moderate, postural hypotension, urinary urgency and nocturia, and her usual function is someone who generally mobilises independently with a 4-wheeled walker. We often see staff needing to prompt her for safety awareness. She has fluctuating cognition, and previously she's had 1 fall in the past 12 months. However, over the last 6-week period, ESME has had 5 falls. Her falls primarily have occurred overnight or in the early morning when she's trying to get to the bathroom. She's had no major injuries, but we've seen increased bruising, heightened fear of falling, and reduced confidence with her mobility. So she's starting to get scared. You can see that she's starting to get more uneasy with her mobilising, and this might be a situation where we're starting to prompt care staff or even RNs to be able to help her because she is just not as good on her feet as she used to be. From a PACOP point of view, her last profile was done in November 2025. And the significant flags during that profile was at that time her AKPS was 40 and her Rockwood Clinical Frailty Scale was 6. So, as a reminder for everyone, An AKPS of 40 is sitting here. So that's someone, even though Esme can mobilize with a four-wheel walker, she is in bed more than 50% of the time in the day. So she sits there at that 40. And when we look at the Rockwood Clinical Frailty Scale, we look at number 6. She is someone who needs help with all outside activities, with keeping the house. Inside, she often has problems with stairs and needs help with bathing and might need minimal assistance queuing or standby with dressing. So again, this is someone who is probably going to be on your shower list, someone who's going to need full assistance with showering. And when we go back, that's what those two PACOP flags are referring to. So if I open it to the crowd, either in the chat or even if you want to take yourself off mute and share, if this was your resident who over the last 6 weeks has had 5 falls and this is what you were seeing, what would you be thinking? What are your main concerns? And what are the things that you are starting to flag or thinking about flagging? I can see my chat, so I might open that up as well. If you have any commentary that you want to pop in there, or even want to discuss, if that was your resident, what would you want to do? Or alternatively, what's your post-fall process here? What are the things that you would be thinking of if you've got a resident that's had this many falls? Even simply post-fall, what are the things that you will be doing or considering doing for this resident if it was someone living in your aged care home?
Hey, Kaitlyn, can you hear me?
I can.
It's Karen from Caloundra. How are you?
Yeah, good.
That's
Thanks for
good.
sharing, Karen. Tell me
Right.
what you're thinking.
Well, what am I thinking? I'm thinking one of my residents is similar, but not quite. The difference between mine and this lady is she's got severe dementia. But so at the moment we have looked at her medications.
Yeah.
And look at the contraindications and the complexities around multiple medications. She also has a bit of hypotension when she stands up. So looking at that, her biggest thing was rolling out of bed, actually, more around the fact that the sheets were tucked in and she'd get herself tangled and would fall out of bed, unable to get herself out. So we got rid of sheets and put a doona on, thinking that might help, which hasn't really helped either, to be honest. She doesn't particularly mobilise to the bathroom. She just gets up due to the dementia. We've also got sensors in place, obviously, regular rounding in place, obviously. She has been also reviewed by GPs, frail and aged, in regards to looking at what's causing maybe her agitation, because she is a frequent faller.
Yeah.
She's either sitting somewhere and snoozing because she's awake half the night, or she's walking with purpose pretty much around the days. Very hard to get food into her because she doesn't sit down long enough for it. She's on a modified diet. She is on outcomes, obviously.
So yeah. if I hold you there, Karen, is this something that you think would probably be an outcomes person?
Absolutely.
I've got another comment in the chat here as well about checking midstream urine and delirium scale. Also really good thoughts. From your point of view, Karen, are there any direct post-fall processes or things that you would suggest if this was your resident that
perhaps physio review, depending with physio, does she need like strengthening exercises? Does she need they're quite basic, a lot of them, but just sit stands and standing, holding. Does she need four-wheel walker, perhaps, that kind of stuff? what's her vision like as far as things go when she's mobilizing? Does she have peripheral vision or poor peripheral vision? Depending on the room, making sure that, what am I trying to say? How she gets to the bathroom.
Her environment, like assessing her environment, making sure that there's no barriers there.
Correct. So making sure there's a clear pathway to the bathroom for her. There's some form of lighting as well, because it sounds like she might need that. Those sorts of things, sensors in place, whether they're bed or floor.
Yeah, we've also got blood test, rule out infection. Does anyone think, and again, you guys on this session will know more perhaps about this than what I do, but are falls like this considered SIRS events?
They can be.
They can be. In what condition would this be considered a SIRS event? Karen, you can answer this, or we can put it out to someone else if you'd like.
No, someone else can answer that. I'll hang up.
Okay. Thanks, Karen. Thanks for sharing. Right. Can be if ruled out neglect. Okay. So that's another thing when we're talking about falls, is there's that, all of the different conditions and things that we have to consider, not only around our quality indicators, but also around our SIRS. Now, we will move on because there's some more pieces of information to this that will make things a bit clearer. So from a PACOP point of view, and someone said this in the chat earlier as well, we would do a deteriorating resident tool as, in response to this change. So because this lady's profile was done in November, and we're December, January, February, she might be due in February. However, she may not be due for her 3-monthly profile till the end of February, for instance. So if we are not at her date that her profile is due, this is a perfect situation where someone would have that grab and go deteriorating resident tool and be using that. Now, the contributing factors that are the extra things that some of you have already probably thought of and gone to. Physical factors. We're looking at reduced lower limb strength. So, we heard Karen there talking about physios and assessments around limb strength and what ability someone has. Pain from osteoarthritis. Postural hypertension contributing to dizziness. Weight loss, again, very similar to Karen's resident that she has in her facility. Cognitive factors, we're looking at impaired safety awareness, poor recall of needing assistance, and increased confusion at night. Some of that may be medication related, some of it may be generally with her mild to moderate dementia. It could be some other things. Impaired safety awareness, we were talking about the environmental factors as well that are connected to those. You see here low lighting overnight, again, we suggested that thanks to Karen. Urgency to reach the bathroom, and walker not always within reach. Now, the fourth factor that we have to consider are medications. So this particular scenario, this Esme was on antihypertensives, contributing to potentially her hypotension, and she was also on PRN medication, increasing her sedation. So again, if you have someone that is having falls, but they also have mild to moderate dementia or even severe dementia, that is something that we have to always make an assessment and weigh up. So some of my question prompts for you guys here as well is, and again, type in the chat to this, what are some things that you already want to change, or what are some things that you also want to investigate? We've already gone through infection. So we've already looked at bloods, urine sample. My first thought on this as well is looking at medications, like the hypotension and the falls risk with that. Is that something that we need to review and just generally do a medication review? I'm also sort of staring at the pain from osteoarthritis, but also pain from falls. Even if someone is having little falls, in inverted commas, or rolls out of bed, how do we know that she hasn't got increased pain, like soft tissue pain? If you have any other thoughts, again, feel free to put them in the chat. My next question is, if this was your resident in your home, what would you be doing? And what are some things that you already want to change? Our next slide. Each of the falls that Esme has had has increased her musculoskeletal pain. It has also heightened her anxiety and fear of falling and reduced her willingness to mobilize. And she now has increased fatigue and need for reassurance and support. Further to that, her assessment has come up with her pain no longer well controlled post falls. So if this was our resident, I think it's probably safe to say that, pain's probably something that we need to review. Bruising and soft tissue injuries are resulting in decreased comfort, I should say. So again, falls and these types of situations happen so frequently in residential aged care, and it can be a daily occurrence. And sometimes we can find that, we may have staff that desensitize a little bit, or, what tends to get missed is that the slow creep of deterioration and the compounding of repeat falls and repeat soft tissue injuries. And is that, in fact, even if there's not a broken noth or a broken bone of any sort, does that person, in fact, have decreased comfort and that we're not necessarily picking up or realizing? We've also got here that the family is increasingly concerned. So when you have those things, again, I'm going to put it out to the crowd to put in comments or take yourself off mute and discuss. What actions would you want to do for this person? Particularly now that we've got family concern. If you've got a family member that's coming to you, concerned about that mum keeps having these falls and they have a tone about them that is starting to become more and more problematic or concerning to you, what are the things that you would want to do? You can see some responses here. Review care plan, one, assist with mobility. Continue to monitor the resident for pain each shift. So again, we go back to aged care nursing 101 is that we need a good pain assessment in place. Daily vital signs. Request doctor to review her medication for pain and hypotension and organise family conversation and look at advanced care planning. Pain review, care conversation. And we agree with you. So my action prompts that I have in my notes here as well, sleep chart as well. Well done. Yeah, that's a great suggestion. GP review, first and foremost. Pain monitoring, totally agree. And family meeting. A head-to-toe assessment or your version of that. And we also, and I spoke to Karen about this as well, do you think this person should be in PACOP outcomes and why? Again, someone doesn't have to only just go into outcomes because they are at end of life. If you have a moment or an individual where you are using your clinical judgment and someone is also meeting the criteria that their needs are not being met, entering the outcomes collection for an episode of palliative care. Again, as a reminder, palliative care is not just end-of-life care. Palliative care is the whole umbrella term that we are using, particularly in PACOP. In the PACOP framework, we have stable, deteriorating, unstable, and terminal. I don't think this lady is stable. I also don't think this lady at the moment is terminal, but we don't know for sure. But what we do know is that the frequency we need to see to her to have her needs met probably needs to be higher than what it currently is. So we're also going to look at quality indicators. So the three that I thought of in relation to this case study was weight loss. Again, very similar to the real life example that Karen shared earlier. That person is probably not, whether it's due to frailty, deterioration, or actually being in pain, that person's not going to probably want to eat all that much. So weight loss is possibly going to be something that's flagging on that person's quality indicators and for what you're submitting month to month and recording. Falls, again, someone's going to be recording that on quality indicators. Skin integrity, again, those of you on the call are probably going to know slightly more about this than what I do around bruising and soft tissue when it comes to skin integrity and whether that is something that you're recording on your quality indicators. Also polypharmacy, so medication reviews, GP reviews, that sort of thing. Using the deteriorating resident tool on this person, what do you think we would find? Before we go into that, did the result of this fall cause significant injury and result in a SIRS event? We don't really know because it's a case study and it is a bit of a case-by-case scenario if this was happening in real life. But significant injury, that's where I suppose I was trying to unpack the difference between having a knock fracture and breaking a hip versus soft tissue and bruising. And do we in fact sometimes have people fall through the gaps a little bit with little falls or little incidents like this, and not necessarily be as responsive as we could be? What interventions are required? We've already discussed that, and what needs to be reassessed. So we would, in this case, use our deteriorating resident tool and transfer ESME, if this was our resident, into the outcomes collection. Bit of a reminder of the deteriorating resident tool. Some of you may have PAL Centre digital versions of this. Others of you who have been familiar with PACOP training will have seen this in our suite of education material. You will recognise that we go through the SAS, the problem severity score, the AKPS, the Rockwood, and then go straight to the identifying the need for palliative care. So this can be a grab and go tool that you can use at any time in between 3 monthly assessments. And this tool has, a palliative care context to it. And it's something that we really encourage. Now, interestingly enough, what our information is telling us for those that are interested in reporting and data is that 80% of residents that end up in the outcomes collection do so because they've been screened with a deteriorating resident tool. So it's a really good pause point to go, if you see someone that has that slow creep of deterioration or, that slow creep of additional frailty or just little signs that you can tell that someone's just not as good as they used to be, is this a moment that you can use that? Now, we know that ESME last time was an AKPS of 40. That may or may not be the same. But even if we're not seeing someone's Rockwood change to the 8, which is completely dependent, approaching end of life, typically they could not recover from even a minor illness. In ESME's situation, we may still have 2 out of the 3 because we have moderate and severe distress. She's not a happy lady. She is not comfortable and things are not in a good place for her at the moment. So we know that she has some distress from pain. Whether or not she can articulate it or not is a different thing. But from the case scenario that we just went through, she has got some distress from pain. She has got some distress around her fear. So fear of falling. She may have some other symptoms or things there that are distressing her as well. But even if we look at just the SAS and the AKPS alone, there's 2 flags there that probably would equal that she's going to be in outcomes. If we look at the problem severity score from a nurse or clinician point of view, sort of me too as an RN, I am moderately, if not severely, concerned about her pain. I'm also moderately concerned about her musculoskeletal strength, psychosocial, spiritual well-being. I'm probably moderately concerned about that for her as well because she's starting to get a bit of anxiety and fear. And also we've got family and carer problems starting to creep up as well into the moderate. So we've got things flagging in the symptom assessment scale, things flagging in the problem severity score, AKPS of 40. Rockwood, we may not be too far changed from that. We may be a 7, but when we look at the identifying the need for palliative care, based on my clinical judgment and current assessments and all the information available to you, do I believe the resident would benefit from an episode of palliative care at the moment? I would say yes. If we go to the next slide, it probably is a bit clearer for you. I'll zoom in. The family in this instance probably wouldn't directly request a palliative care situation from you. However, they are still concerned. We can hear that they are still very concerned and starting to get, more and more observant and a bit worried for their mum. Based on clinical judgment and the current assessment, do you believe that the resident has a prognosis of less than 3 months? Don't know whether that's a yes or no because I can't see her in front of me, but we definitely have 1 or more moderate or severe symptoms in SAS and problem severity score, and she has an AKPS of 40 or less. Even if her Rockwood if we don't even put her Rockwood at an 8 and she still stays a 7, we still have 3 criteria there that's a yes. And if we hit yes to any of those criteria in a DRT, the resident would benefit from going into the PACOP outcomes collection. And yes, Kerry, thank you. DRT would support evidence assessment on the resident that has been affected by the fall. So what do we mean by the outcomes collection and starting an episode of palliative care? We mean that person, similar to chapters in a book, I like to describe it. So that person may need a chapter or an episode at the moment where we need to deliver more concentrated care because something has changed in their needs. So we have a start and an end to that chapter or that episode. In this instance, for Esme, I would probably be saying the reason we're starting this episode is because she has advancing frailty with old age. The full clinical assessment we do for someone in outcomes, either weekly or daily, by a healthcare professional, dependent on what phase someone is in. So you can see here we have the symptom assessment scale, which we know from profile and the DRT, the problem severity score. We have pain check there. If you are an aged care home that uses pain check, we can integrate that into your PACOP practice as well. We know the AKPS here is 40. We have RUG ADL, again, should be familiar to a lot of you. But what we need to determine in this case for Esme is her palliative care phase. So if I go to the next slide, we know Esme is definitely going to start an episode in outcomes and we're going to complete a full clinical assessment. But then we need to ask, is she expected to die within days or weeks? I don't think she is. So I would personally put no to that. Again, if this is your resident in real life, your answer and your clinical judgment is going to determine that answer for you. But for the sake of this and the type of resident that I'm imagining in my mind, I would probably say no. Does the current care plan meet her needs? I would say definitely not because of the pain, the discomfort, the frequent falls, the bruising, the postural hypertension. Something's going on there. Is urgent action or further assessment required to meet this resident's needs? There is no definitive right or wrong answer to this. I could say if I was super concerned and I was not comfortable and Esme was on, in my care and I wanted to address everything really urgently because I thought the need was such, I could put her in unstable and I could hop on the phone and call a doctor and get that reviewed. If it was a different person, if it was a different circumstance and you did not look at someone like that as with the same level of urgency because she was on the GP review list for Thursday's GP rounds and you had enough PRNs and other things to meet as many needs as you could for the time, you might put no, I don't need it urgently reviewed, all of this situation. I might lean more to deteriorating phase. Review and update care plan with interventions for anticipated needs. So does anyone have any questions or thoughts around the phase, either in your own experience or with Esme, our case study resident? I'll move on, but if you do have any questions, please feel free to put it in the chat. So that phase is what determines how often we do our full clinical assessment. Those residents that are stable and deteriorating, who in my assessment for Esme would be her being in deteriorating phase today, we would be doing a daily SAS for her and weekly full clinical assessment. If so you had a resident that was unstable or terminal, they too are having a daily SAS, but they also are having a daily full clinical assessment because their needs and their need for staff to be more responsive is higher. So we're going to be seeing to them daily. Now, this is also where we segue into the daily SAS conversation. So again, some of you may be very familiar with the daily SAS and hearing that such and such or this resident is on daily SAS. What that actually means is that resident is in the outcomes collection, and every resident in the outcomes collection needs a daily SAS to be completed. And because of the nature of aged care homes and where we work and our education model that we have within the PACOP framework, we extend that to our care staff. So what you see here is a symptom assessment scale, daily SAS, that we have an accompanying SAS score guide for care staff who can report back to the RN what they see regarding each of those distress of symptom assessment. They will report that back to their RNs. So you may see RNs or staff being delegated a daily SAS to complete using our rulers, which you may have seen as well. And that daily SAS, again, if I today see Esme as a deteriorating person, but tomorrow's daily SAS, she has severe distress from pain and severe distress from anxiety, and her numbers on her SAS has changed, I am going to go back and change her from deteriorating and use that information to maybe put her into unstable because something significant has changed, and I don't want to dilly-dally and I don't want to waste time trying to work out how to reduce that distress and help Esme. I need to act a bit more urgently than what I did today. And that means her phase would change. But that also means that her rate of full clinical assessment would change as well until such time if her phase changed again. Any questions in the group around the 4 phases? So the phases are not sequential. You can go in and out of any phase, but the phase determines the frequency of the RN full clinical assessment. Any thoughts, questions? Any reflections, perhaps, on residents that have been in similar situations? I think for me, key learnings around sharing a story like this is around using that deteriorating resident tool, knowing that most residents are probably going to enter outcomes by someone seeing that that particular resident is not doing well, and they are screened and popped into the outcomes collection almost on a whim. It's the DRT use is designed to be on a whim when your red flags are going up and you see something is not right with someone, and using that as to segue to change the position that resident is in your triage list almost. I also think that this particular case study looks at recognition of falls and frailty as an actual concern. I have memories of working in residential aged care where people fell semi-regularly and they weren't big falls. There was no major fractures, but it was almost like it was normalized that when people get old and residents in our aged care homes get old, they get more frail, and that's just what happens to them. And it was almost like this normalization and desensitization of people falling over and, residents getting a bit sore and hurt from it. And that's just what happened. And I think now that I know what I know, and we have a framework such as the PACOP framework to apply, that isn't so. Those situations and that kind of subtle or not subtle change in frailty and falls is actually a sign that that person's needs are changing and they are moving to a different space under the palliative care umbrella. They're not end of life yet, but they are also not stable and something is happening. And we need to use those experiences and those pieces of information around falls and bruising and different things, different levels of discomfort or feedback you are getting from your resident, whether that feedback is with their words or whether it's that feedback is coming from their behaviours and what they're displaying. That is something that we probably can work together to not normalise and use that to start that proactive palliative care planning, perhaps. I also want to highlight that the communities of practice that PACOP facilitators run on a monthly basis are a safe space to discuss case scenarios like this. Again, some of you are probably participants in those communities of practice quite regularly, others it may be completely new to you, but our communities of practice sometimes not only talk about the implementation and how people are going with their data or how the practice is going. Sometimes that the community of practice goes to a space where we reflect and talk about what's currently happening with maybe some of our high-risk residents or people that have fallen over quite a lot recently and, unpacking what it is we want to do, is it the right direction, and maybe learnings that we have got from that experience. Our communities of practice, again, are facilitated and supported by us as improvement facilitators. Regular meetings are held based on needs. Again, some aged care homes and organisations are on monthly communities of practice. Some may need more frequent if you are only just starting out with PACOP and you need a bit more support to get going with implementation, or you have a lot of stuff going on with high-risk residents, then we may need to see people more frequently. And supported implementation through strategic planning. In terms of our resources, if you've found today helpful or just interested in what we have out there, we have our resources on our website. Some of those of you that have been linked to our resource hub as well. We have our clinical guides, which may come in handy a lot for situations like ESMEs. If you have got someone who you can see their assessment numbers are changing and you want to refer to a guide or see what our PACOP program would suggest if that was happening, then you can find those on our resource hub. We also have our training videos that are available on YouTube, lanyard cards, SAS rulers. Also, you can see here we've recently got some translated resources for residents and families. If that's something that your particular facility needs, do let us know and we can link you directly to those. E-learning courses as well. If you think that your team maybe is due for a refresher or you've got some new staff that have started and you want to set them up with the foundations before they perhaps go to a PACOP workshop or start assessing people in real life, our e-learning courses are really useful to set everyone up for that, including our SAS for Care Workers session. We've got that as an e-learning module as well. Speaking of our SAS for Care Workers, I am also hosting a webinar for that later this month. So if that is something that you are interested in signing up your care workers for, if you are a PACOP participating aged care home who are trying to extend the PACOP ethos to your care staff, and you want them to try and build their skills a little bit and be able to effectively report up to the RNs, then certainly even if you sign up a group and put the webinar live up in a training room on a screen, happy for that to happen as well, but it gives that opportunity for the care staff to attend if that is possible. Other than that, we are about to wrap up. Are there any questions, thoughts, reflections that anyone would like to share around frailty and frequent fallers? I'm going to put back Esme's story here and look at our contributing factors, because I think, again, like Karen said, I think it's really common, a really common case scenario, really common setting to see this in people. And again, to have sometimes our teams, because we have other demands, other things that happen. Sometimes it can also be the squeaky wheel gets the oil. Sometimes there's another family or another resident. Residents like Esme and her story can fly under the radar a little bit. So it's about being able to see that in a different light and be able to bring that palliative care lens to someone like Esme when these things are happening. Not to be overreactive, but to be proactive in palliative care planning for someone like Esme. Thank you, everybody, and have a good afternoon.
Thanks, Kaitlyn.
Thank you. Bye for now.
Bye.